Okay, so a G tube is a tube, it's a gastric tube, okay? It is surgically implanted. It is a surgery, okay? The doctor will go in by endoscopy through the mouth right here, down into here, and then they're going to poke a hole to the outside and then put a little button in there. Okay. And that will go right into the stomach, and then you can use the G button connected to a G tube. So this right here is the actual G button. That's what you'll see outside the patient. That's all you'll see. Little button. Okay. Let me show you what it actually looks like when you look at a patient. Um,
And you said it's only surgery?
it's surgically implanted. Yes. Now the PEG tube is called a percutaneous. And so that one they can actually just poke through the skin and they don't require surgery. But the G tube requires a full surgery. Okay. Okay. So this is what a G button looks like. It looks like that. It's flush against the skin. Most kids will wear like a little belt or something around it because it gets caught on stuff.
Okay.
Then you're going to open up that little thing right there. Okay. And then you're going to connect that to the tube. And then that's how you do the feeds. So this is the G button. Then the tube that you connect to it is called a G tube. Okay. All right. So it is placed by a surgeon and people will need it. A lot of kids have these actually. If they need long-term enteral feeds, so we know that they're going to be feeding enterally for a very long time, it might be better because NG tubes are very uncomfortable.
Yeah.
So that's why we see it a lot in the NICU or in these little ones. If it's a baby who's not going to be able to feed by mouth for quite some time, or they're not going to be able to feed by mouth enough, then we'll just go ahead and place a G tube. But just because a kid has a G tube or an NG tube or an adult doesn't mean they can't still feed by mouth. Some of them can. Okay. They may just not be able to get in enough calories. Okay. But some of them can't. Okay. So long-term enteral feeds, patients that are comatose, that obviously they're not going to be taking feeds by mouth, right?
Yeah.
Okay. Severe GERD with esophageal ulcerations. Again, we see this a lot in our NICU babies. So some babies have really bad GERD and they got GERD so bad that it caused ulcerations in their esophagus. Then every time that baby ate, it burned. So they will start refusing bottles completely and will not feed by mouth. Then of course, yes, it hurts like hell. Yeah. So then of course we'd have to put in a tube at that point. Okay. So like I said, the difference between a G tube and a PEG tube, the PEG tube is inserted through the skin without general anesthesia. Of course, we're going to use local because that would be barbaric if you just poked a hole through someone's stomach. Okay. But do you understand like a PEG tube goes from the outside in and then in putting in a G tube, they're going inside and poking out. Okay. All right. In a new G tube, there is going to be a little bleeding or redness because they just had a hole poked, right? Yeah. So when it's brand new, that's normal. Okay. You're going to clean the outside with only normal saline. We do not use hydrogen peroxide or anything else. And plus it's brand new. It's going to be very tender skin, right? Mm-hmm. But you do need to report any purulent drainage. That's pus, right? Purulent drainage means pus. Okay. Or if it's severely painful, that's not normal. Okay. After 10 days that they have had the new G button, you need to start rotating it at least once a day because it does get real crusty. Okay. And it'll get kind of stuck. So at least once a day, we just turn it. Okay. And that's after 10 days after the surgery though, especially when they have a new G tube, check residuals because their gut may not be ready. They just had surgery. They just had anesthesia. And then when you give their first feed, it may not be moving that feed at all. So definitely make sure you check a residual. Okay. All right. So for nursing care, you're going to apply the pre-cut gauze dressing around the stoma. Now there are some that there's a package and it will say pre-cut. Now, the reason why we use pre-cut, you can't take a regular gauze because there's like 4x4 gauze or whatever, or like 2x2, and people would cut it. But there's all those little fibers that come off of it, and that can get inside the stoma. So make sure that you use pre-cut. Okay. Make sure that the balloon is inflated properly. So when you stick the G button in, it has to have a balloon, kind of like a Foley calf, in order to keep it in place. Otherwise, it would just fall out all the time. So just make sure that that's inflated properly. You are to clean the stoma site every day with soap and water, and then pat it dry. Okay. Apply a skin barrier. So it's like it's a liquid. Sometimes they even it looks like an alcohol pad, but it'll say skin barrier on it. Okay. You put it on there. It looks like liquid when you put it on, but it dries. And that way, if any like formula or anything gets on the skin, it sits on the skin barrier instead of on their skin. Okay. Instruct the patient to wear loose clothing because, like I said, it can't get stuck on stuff. So if you're wearing like tight jeans or something, I've seen it get stuck on that and pull it, and it hurts very bad. Okay. Notify the physician. So what are things you would notify the physician for? If the skin is really red and really painful and it's not new. Okay. If the residual is greater than 250, and that would be in adults, obviously. Okay. Because at that point, that would be like basically their whole feed. Okay. If the stoma is any other color other than pink, stoma should be pink. That's the hole. The stoma means the hole, right?
Yes.
You know what I'm talking about?
Mm-hmm.
Okay. So that tissue should be pink. If it is black, gray, blue, any other color, that means it is not getting perfusion. It is dying, and you should call and report that immediately. Okay. If they accidentally pull the G tube out, now that's going to hurt like hell, first and foremost, because there's a balloon in it, kind of like pulling out your Foley cath with the balloon. Yeah. So you're going to take a sterile gauze, put it on the site, because it looks like a gunshot wound at that point. Okay. I had a kid do this to me. Yes. Okay. So there's this kid. I was a brand new nurse in PD. Okay. And there was an 18-month-old little girl, but she had had a G tube since she was born. So she was very used to it. Okay. And she had been in the hospital for a very long time, and she knew all the nurses there, but I was brand new. Okay. And they're like, hey, we're going to give you her because she's very stable. She's been in here for months. You know, we're going to give you her. So she looks over. She's 18 months, keep in mind, a year and a half. She looks over at me, and it's like she knew
you were new.
You're not here. And she just reached in and pulled it out, and it starts spurting blood. Like, and I was like, ah! So I like grab a gauze because I remember this, and I like put pressure on it, and she's laughing, right? And I look over, and the mom's like, I see her go like this. Like this. I'm like, oh my gosh, she's gonna faint. She saw the blood and she's gonna faint. But I have my hand on this kid's abdomen. So I'm like, do I grab the mom or do I hold the kid? So I grab the mom like this, and she faints on me, and then I let her like slide down my leg because I couldn't let go of like the bloody thing. So I'm like, brand new nurse, and I'm like, she's like, help. It was horrible. So you're gonna take sterile gauze, put it over there because it'll bleed. I mean, it won't spurt, but it will trickle, right? Because it depends on how big the balloon is, but it's impressive. And then you just hold your hand there, and like it says notify the MD, but really you're going to call out for your friends, right? Because you're going to need their help first. And then the doctor can actually come out and try to put it back at the bedside because they can deflate the balloon and try to stick it back in. But if they pulled it out with the balloon, sometimes it's already like really swollen and you can't get it back in. So they may have to go back into surgery, but they will try at the bedside. Okay.
Would the surgery be because they would have to like stitch?
No, the surgery would be because I can't fit the G tube in because there was so much swelling. Okay. So I'd probably have to go in and make a bigger incision. Okay. And then when they actually remove G tubes, because they're not permanent, you can take them out. We take them out of the bedside and stitch them. You don't. But no. Like the nurse, you can actually take it out, and some you could do that because all you have to do is deflate the balloon and take it out. And then the doctor or the NP will just make a couple stitches. If even that, some people like their stoma looks so good it'll heal on its own. We just put sterile gauze on it and it'll heal. Okay. Questions on G tube feeds? Okay. All right, so let's talk about NG tube feeds. So nasogastric tube. Gastric means
like stomach.
Sorry, okay, so NG tube feeds are considered an enteral nutrition because enteral nutrition means it goes into your GI system somehow. Parenteral nutrition, that's TPN. Okay, so enteral, it goes into your gut. Parenteral, it goes into your vein. Okay. All right, so who cannot get NG tube feeds? If they're at any risk of aspiration, they should not get an NG tube because you're sticking a tube in the back. Yeah. Okay. If they have a dysfunctional gag reflex, so if they gag all the time, you probably should not put an NG tube down because they're going to be gagging continually and vomiting. If they have gastroparesis, so gastroparesis is when their stomach gets basically paralyzed. Okay. If their gut does not move, well, not gut, their stomach, it's specifically their stomach because it says gastro, then you shouldn't put feedings in it, right?
Right.
If they have GERD, don't put it in NG tube because they're going to be aspirating, right? And they're probably their esophagus is already very irritated. Okay, this one's a big one for NCLEX, and I know you're way far away from that, but I'm just telling you it's coming. If a patient has any facial trauma, you cannot put a tube in their nose. That means like if they got in a fist fight, okay? If they've been in a motor vehicle accident and there's facial trauma. Because if bones are broken here and you try to go in an NG tube and something is broken, it can go into the brain. Oh, yeah, that's a big effing deal. Okay. Yeah. So don't do that. Okay.
When it means facial trauma, it means actually something broken, or can it just be even if it was...
Well, I don't know if anything's broken when they come in, right? So if they've had any facial trauma, then until it's cleared and shows there is no broken bones and everything is fine, maybe there's some bruising or something. Yeah, if there's bruising, that's fine. But like until I know for sure that there are no fractures, nothing is displaced, nothing like that, then I'm not putting anything to. Yes. Or you can drop an OG tube, an oral gastric tube, right? But you can't put anything in the nose. Okay. All right. There are two ways to feed patients, either continuous, you'll do a small amount all the time. Okay. Or you can do bolus feeds, or also called intermittent feeds, where you do a larger amount at like meal times. Okay. So they'll have like breakfast, lunch, dinner, but it's all still liquid, right? Okay. All right. I did not put how to check placement because I think I did that on another video somewhere, but you know how to measure?
Yes,
Did y'all do this from the nose to the ear and then
earlobe,
to the xiphoid process?
yeah.
Okay. So to check placement, this is often on exams, the only way to verify placement is to do a chest x-ray. Okay. That will verify the initial placement. After that, obviously, I mean, if you're feeding them 5 times a day, you can't do 5 chest x-rays or you'll kill them with radiation, right? So after that, we can use the aspirate where you aspirate some stomach contents, put it on the pH paper, and you test the pH of the contents. If it is less than 5.5, then that is considered that it's in the stomach. Okay. All right, other tubes I'm just going to mention. There's a PEG tube that goes right into, that's a gastric tube, a G tube. Okay. And then there's an actual like G tube that's put in surgically. There's an OG tube, which is an oral gastric tube. So you put a tube in their mouth and that goes down to the stomach. We do that mostly in neonates because they don't have a gag reflex. So it's easy to put in their mouth. And then there's a J tube, and then the J tube goes in the jejunum. So that goes lower in the intestines. Okay. All right. Administration. So you can usually we'll put well, there's 2 ways to administer, right? Basically, is what I'm saying. There's a kangaroo pump. So you can actually, have you seen one of these? Do you know a kangaroo pump? Okay. So we usually use it for kids. Sometimes you can use it for grown-ups too. But it's where you put the feed in a bag. Okay. And then you let the bag, it's kind of like an IV pump for feeds. And it like puts it into your patient. Okay. It's nice because you don't have to stand there the entire time, right?
Yeah.
And patients can do this at home. They can use the kangaroo pump at home. Okay, let me see if I can show you one. It really does kind of look like an IV. Okay, so there's the pump, and then you hang the bag up there, and then you connect the bag to the pump, and then it pumps it into your patient. Whether it's an NG tube or an OG tube or wherever it is, it's safer because it gives us, a smaller amount more continuously. Because if you try to give a feed too quickly and their body was not ready for it. Okay. So like when we're getting ready to eat, like we hungry, right? And your mouth's already like salivating because you like went to Outback and you can smell the steak or whatever. And your body's already making enzymes before you even eat. They are not like that. Okay. I don't know if you've ever smelled this formula, but it smells like death's doorstep. Okay. It smells horrible. And they don't want it. I mean, they don't even taste it anyway. So they do not there's no preparation in their body for food. So if you dump a bunch of food in their stomach or their gut and it was not ready, your gut panics and it will dump it. And that is called dumping syndrome. Literally, think of like the time you've had to poop like the worst in your entire life and like you thought you were going to absolutely shit your pants. That's what they feel like. They start sweating, they get a high heart rate, and then they just have massive blowout diarrhea. And that's because you gave the feed too fast. So that's why I like the kangaroo pump, because there's a certain way that you can put it in there, right? And it will give them a certain amount and you can't like overfeed too quickly. The other option, that's what this picture right here is a gravity feed. So you connect a syringe that doesn't have the end on it, okay? And you connect that to the tube and then you just stand there and let the feed go in by gravity. The problem I have with this is it's very easy for it to go in too quickly accidentally, okay? Because I've been feeding a baby before, because I've only ever done inpatient peds, feeding a baby, and then somebody came in, they're like, hey, you got a critical lab on this patient, blah, 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 blah. And I'm like, oh, okay. And then I look around and the whole feed is already done. It was an accident, right? Yeah. But then the kid's like, pooping all over the place. So gravity feeds, I don't like them. I don't think they're safe. The other thing you have to be careful of too is and this happened a lot in pediatrics, if the kid's crying and you've got a gravity feed, the air and that pressure will go back up into the syringe, and I've had it like all over the place. Okay. So yeah, the gravity feeds are not for me. Anyhow. Okay. So must knows for NG2 feeding. No matter what you put through there, you have to check placement every single time, because that tube is very flimsy and it can curl up anywhere at any time and go somewhere else. So it could be in the lungs for all you know, even though you just fed them 3 hours ago. Okay. So you have to check placement before you flush it, before you put meds down it, before you feed anyone, because you don't want to put a bunch of feed in their lungs.
I think in our book for that one, they said something about you could put it into like a cup and see those bubbles in it, like the end of it.
See if it's bubbles. No.
That's what I was wondering. I thought I read something.
No, you're supposed to do either pH aspirate. You can also do just a tube measurement because you're going to measure how long it is, right? There is a CO2 check that they have used before, but I haven't ever actually seen that used in any hospital ever. Maybe that's what they're talking about. I don't know. All right. Anytime you flush, you're going to flush with sterile water only. We don't put saline in someone's tummy, right? Okay.
Salty.
Yeah. You're going to check a residual before every feed. And a residual is how much is left in their stomach since the last feed.
Okay.
So let's say you have a patient that gets Q4-hour feeds and they get 240 mLs per feed. Okay. So you're supposed to feed them at 8 o'clock and at 12 o'clock. So you fed them at 8, they got 240 mLs. Okay. Then at 12 o'clock, they're due for another feed, but I need to make sure that last feed actually went down. So I'm going to stick an empty syringe and attach it to the end of the tube, and then I'm going to pull back and aspirate as far back as I can go and see how much is still in there. Let's say they have 200 residual. That means that in 4 hours, only 40 mLs went down. Do I want to give them another 240? No, I would call the doctor and be like, we have a residual of 200. Do you want to hold this feed? Okay. All right. Place a patient at 30 to 45 degrees to feed and up to 1 hour later, because even though you have an NG tube, you can still puke, right? Yeah. So I don't want them laying flat. Do not give it too fast. What happens if you give it too fast? Dumping syndrome. Massive diarrhea. I mean, and it's called dumping syndrome. I mean, you can't mess that up, right? Okay. Do not add meds to the formula. Now you can put meds in the tube, but you shouldn't add meds to their formula, because if you accidentally drop the syringe, okay, or if, like I said, they pushed for some reason and it bubbles back up, you've lost all the meds, right? And in that kangaroo pump, you don't want to add medicine, because what if you have to stop the feed for some reason? I have no idea how much medicine they got because it's sitting in 300 mLs of a formula, right? Okay. So you can do the meds first, or you can do the meds after through the tube, but you can't add it to the formula. Okay. Discard the formula after 4 hours. It can only sit out for 4 hours and then it's contaminated. Okay. And this is especially important on the unit because I've seen a lot of nurses who are very lazy. So on that kangaroo pump, they'll put like 8 hours of formula in there one time, then they don't have to check it again. But that formula just sits there for like 8 hours. It's disgusting. Okay. So an extra 4 hours because they couldn't be bothered. Or what they'll do is they'll put 4 hours in at a time, but they don't wait the full 4 hours and then come in and put another 4 hours. But basically you're pouring old formula in, new formula. That's gross. So you should really put 4 hours in at a time and then just leave it, let it drain all the way, and then put the next 4 hours in if you're on continuous feeds. Okay. All right. Complications. They can aspirate. That is possible because there's a tube back there and it's really uncomfortable. So head of the bed needs to be at 35 to 40 degrees. Okay. If there's a clogged tube, flush gently with sterile water. Don't ever force anything into a tube. That's across the board for every tube in the history of all time. Okay. But you can do it in like a flushing motion where you like pull back, push, like this with a syringe and try to get it to kind of flush out. If they are getting diarrhea from the feeds, which is common because it's nasty and it's very high sodium and salt content. Okay. So if they're getting diarrhea from it, just slow it down because remember that usually means you're giving it too fast. Okay. If they start vomiting during the feed, the first thing you do is stop the feed. Yes. And then you're going to sit them upright because I don't want them to aspirate. Okay. Suction out their mouth if you need to. Okay. All right. Feeding bags should be at least 12 inches above the stomach. If it's below your patient, it's not going to drain into your patient. Okay. Flush tube with 30 to 50 mLs of water between meds, after meds, and then before and after feeds. Okay. That's only for adults. If you did that to children, they would be waterlogged. Okay. Priming the line. Was it you and I that was talking about priming the line?
No.
Okay. Do you know what priming a line is? Okay. So to prime a line, and you do this with IVs, you do this with everything. So this is actually an IV. Okay. So you would stick this part into the IV bag, right? And then you need to let the fluid run down the whole entire length of the tube. I'll like just hold this over a trash can and let it run until it starts like spewing out at the end, and then I'll clamp it. Okay. Now the reason why I do that is because now the line is what we call primed with, let's say, normal saline that I was hanging.
Okay.
If I didn't, I just stuck it in my patient, this entire length of tubing is filled with air. And I would be putting all that air in my patient. Okay. I don't want to do that for feedings either because then I'm putting a bunch of air into their stomach and they're going to either be like really farty or like really gassy and like burp a lot and it's really uncomfortable. So you want to prime that line with formula, right? Before you give it to your pediatrics. That way they don't get a bunch of air in there.
You want to make sure that there's not much air. Just basically the liquid.
Yes, that's right. Okay. All right. And then if they are on continuous feeds, which means a lower amount, but they're on it for a long time. And sometimes the continuous feeds too are just overnight. Like a patient can eat by mouth during the day, but they just can't eat enough to maintain their own nutrition. And then at nighttime, they'll hook them up to the pump and let that pump run 8 hours at nighttime. So they get a bunch of extra calories at night. Okay. But if you're doing continuous, you need to check the placement, okay, before you start it. Check the residual before you start it, okay, and then flush every 4 hours, okay, because that tube can get clogged if it's sitting there for like 8 hours just continually running formula. Okay. And then goals for the NG tube feed, that's in red. Our goals are that they will have no nausea and vomiting, No diarrhea or constipation, no abdominal pain or distension. If any of those happen, that's not normal and you need to figure out what's going on. Okay. We want minimal gastric residual. You're going to have some left in your stomach. I mean, that's natural, right? And they have positive bowel sounds. That's what I want to see happening with these feeds. Got it? Okay. As I've been sitting in there eating. Okay, cool. So we're going to do total parental nutrition. All right. So this is a bag of nutrition that goes through your vein. Okay. Oh, sorry. Oh, I thought you said, I don't know what I thought you said. Okay. So these are total parenteral nutrition we don't give very often. It's called TPN. Okay. You haven't had clinical yet still? When are they going to put you all in the hospital?
They've already had other people, but we go to Kindred. I think that's what's called.
Kindred.
Yeah. And they would not allow us to come in until after the Easter holiday.
Gotcha.
And so we don't start until April 15th.
Okay. So TPN is this big bag. It looks like it's kind of a yellowish color, and it's for patients that cannot have anything in their gut. Like they can't have NG tube feeds, they can't have G tube feeds, they can't drink things by mouth. Like something is wrong with their gut that they cannot have anything going in PO. Okay. TPN is reserved for the most dire situations because it kills your liver when you take it. So we don't see this very often. You won't do it very often because it can really cause a lot more harm than it does good. But TPN you would want to give to patients who we know won't be able to have or maintain their own nutrition for a very long period of time. Okay. So even if they're going to be in PO for like 7 days, we just put them in PO and put them on fluids, right? Because starting TPN is dangerous. It's got to go through a central line. So it means I'd have to start a central line, which means that's a risk of infection. So it's got a lot of things that go along with it. All right. But it is nutritional support. It does go intravenous. Okay. And it is a hypertonic solution because it's very, very thick. Okay. All right. So what's in it? So basically they have to take everything your body's supposed to take in an entire day and put it in one bag of fluid. So it has a huge amount of dextrose, which is your sugar, amino acids, those are your proteins, right? All of your electrolytes, all your vitamins, all of your micronutrients, which is like your zinc and all of that stuff. All your fluids for the day, all your folic acid, and all your calories in one bag. So you can see how it's very thick, it's very viscous, and then your liver has to metabolize all of that. 23 hours a day. One bag will last 23 hours. Okay. So who needs this? If they have massive GI damage, if they have malabsorption of the gut, basically that means like they've had massive Crohn's or like their gut is basically just like a bloody mess right now. If the patient has severe burns, now we do like to feed our patients with burns and at least put something in their gut, but we may not be able to get enough in the gut to maintain their calories. So we may also do TPN. If they have any motility disorders, so those would be people that when they drank or ate something, their stomach does not move. So it just sits there. They obviously cannot eat by mouth because it would just sit there. Okay. If they're going to be NPO for more than 14 days. So if they're going to be NPO for 12 days, I ain't doing nothing other than don't eat and here's some IV fluids. Okay. All right. They have to, or most of them will have insulin with it because you're giving them such a high amount of dextrose 23 hours a day. But you have to, because you have to give them their sugar for their whole day. But even if they're not diabetic, they might have to have insulin because you're giving like a concentration of D10 or D15. Okay. And then sometimes we add heparin into it. Do you know what heparin is? It's a blood thinner. So they will add it into the bag to make sure, because you're going through a central line, which is a big, giant lumen, and it can get clotted. So they may add heparin to make sure that you do not clot your line. Okay. It has to be administered through a central line. Do you know what a central line is?
Would that be like a main vein?
Like it goes right into the heart.
So
okay. So this picture right here.
Is that the inferior?
It's going to go through the inferior vena cava. Yeah. So they will insert it either into the chest, or there's also a PICC line that they can insert through this artery here, but it's going into an artery. Okay. It's called intravenous, but really it ends up going into a major artery and right into their blood supply. Okay. So it's got to be through a central line because it is very, very thick. It is very, very viscous. Okay. And it can be very damaging if you try to give it through a peripheral IV. If that peripheral IV extravasates or comes out of the vessel and the TPN gets underneath your skin, it can eat away your entire skin. Okay. So it really needs to be through a central line. Okay. All right. It is hepatotoxic. Like I said, your liver has to metabolize all that stuff in the bag. So if you have somebody on TPN, you have to draw LFTs, which are liver function test, every morning at 0400. Okay. All right. TPN also is not compatible with many drugs. So most of the time they'll put in a double lumen TPN. Okay. So that means the line is going into the patient, but when it comes out of the patient, it splits like this. And there's one port here and one port here.
Okay.
So then one line you will label and put TPN only,
Okay.
and then in one line you label meds only.
Okay.
There's also a triple lumen. So you could do TPN only, meds, fluids.
Okay.
And there's a quadruple lumen. TPN, meds, fluids, and then the last one you could use like for blood draws or if you have to give lipids or anything like that. But they have to be labeled.
Different valves. I mean, are they still going all into the same?
Oh, I see. So most of them are tunneled, which means that whatever that port is actually tunneled inside the central line. So it will not mix at all inside the line.
Okay.
It'll just dump into the heart all at one time. I'll show you what I mean by this.
Okay.
So like if you have, this is what the port looks like on the outside, right? So we're going to access this little port and then it has this line like this, right?
Mm-hmm.
So I guess maybe in your mind you're thinking it all ends up going into one thing.
I'm thinking like
this.
I'm thinking like piggyback.
Oh no, it's not like that.
Okay,
They all go into like it all has one like on the patient. It has one tube that comes out like this. Okay. But it's central lines are big. Okay. But if you have several different lumens, they will all connect to the one tube. However, if it's tunneled, it'll look like this. You can't see this with your eyes.
Yeah.
This would be on the inside.
I also was
So
thinking
that
like,
this one goes right here and this one goes right here. So they don't ever actually mix inside.
So they never mix. Does it mix once it gets to the heart? Or
Well, not really because it can't. Because it's not like you're putting it in a stomach where it's just sitting in there. It's like being immediately picked up by your blood and goes. So nothing is actually really mixing. If that makes sense. Okay.
I was thinking about two different IV sites.
Uh huh.
You know, when you can't mix the medications.
Uh huh.
Or you can have.
Oh yeah, you can't do that. And also you can start a peripheral line if you want to use it for something else, but these are not going to mix. Okay. All right. So most important, not most important, very important with TPN is to make sure you do a daily weight and albumin levels. What do those tell me?
Fluid intake and
Nutrition. Yes, very good. All right, so complications. During the infusion, a lot of people, even if they're not diabetic, will get hyperglycemia because you're giving them like a D10 or a D15 solution, which is dextrose 10% or dextrose 15%. Okay, now you have to do that because you got to give them all their sugar for the day, right? Okay, but it can cause high blood sugar. So while patients are on TPN, you need to be checking blood sugar. Then remember I told you they're on it 23 hours a day. There is 1 hour where they come off, gives your liver a rest. It also takes about an hour to prepare the next TPN bag, okay? Because each one is a different recipe depending on your patient. So in the morning time when they're on TPN, not only are you drawing LFTs to make sure they're not liver toxic, okay, but you're also going to be drawing all of their electrolytes and all of their vitamin levels and all of that because the doctor uses that to make this recipe for their TPN. Okay. Pharmacy then mixes that bag specifically for that patient, okay? So when it comes up to the unit, you treat it like a blood transfusion. You get it checked with 2 RNs. You have to check every single component of it and make sure everything is correct. You'll have an order that's in the MAR, and then it'll say like dextrose 10%, and you got to go over and look on the back dextrose, and you check it off, and you check every single one of them, and then you have to get another nurse that does that as well. And then there's special TPN tubing, and TPN also requires a filter because it's so thick, and it takes a lot of time to check it, get it all set up, spike the bag, get it primed, keep it sterile. All of that takes a full hour. So in that hour that they're off, you're preparing the next TPN bag. Okay.
So it's basically the hour break for them.
And break for you.
Well, it's not really break for
I mean, but it's like a break for you to at least like get the next thing ready, right?
Okay.
So you have to like prepare in advance because you know it's going to take you an hour to get that TPN bag and they can only be off the TPN for an hour. So you need to have called pharmacy a couple hours early to say like, hey, I need to be hanging my new bag at this time. Okay. So in that 1 hour you're off, you've been giving them 15% dextrose for 23 hours. What happens if you all of a sudden take off the TPN? Their blood sugar is going to plummet, right? Because they've been getting tons of sugar and their pancreas has been producing insulin, 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 insulin. You take away the sugar and it's still making insulin. It will plummet their blood sugar. So when you take off the old TPN bag, you're going to hang up a D5 solution, dextrose 5%, in that 1 hour so that way you don't plummet their blood sugar. Okay. Central lines are sterile. You have to treat them sterile. So anytime you access them, sterile, clean them, sterile, change the dressing, sterile. Okay. So you have to be really careful with that. Do what?
Sterile procedure.
Yes. Everything. Do not use the peripheral nutrition lumen for blood draws. I've seen people try to do this before. Now, nurses love having a central line in their patient because you can use it for blood draws. You don't have to stick them.
Yeah.
But if you've got TPN going through that line, you cannot pull blood. I mean, you can, but you're obviously, it's going to be very altered because you've got TPN in the line. Yeah. So if you try to go send it off for electrolytes, all that TPN is just sitting in the line. So that's why I'm saying you have to label each line and use something for each line for something different. Okay. Draw LFTs at 0400 and then report jaundice because it is very liver toxic. Okay. Draw albumin and protein levels and their electrolytes daily, and we'll use that to make the recipe and see what their nutrition is like. All right. So nursing care, we hang for 23 hours, and then you're going to give D5 and that 1 hour off, and you have to do a blood glucose during that time. Okay. Use an inline filter. There's a filter that attaches to the TPN line because it's so thick, it does have to filter it through. So you have to use an inline filter. Okay. And then if you're giving any meds in the central line, you have to check and make sure it is compatible with TPN or use a different line. Okay. Keep the central line infection-free and sterile. That makes sense. And now the central line dressing has to be changed every 7 days. That is sterile dressing change, or if it gets soiled before 7 days. But that's the nursing requirement, is at least every 7 days. The TPN bag will only last 24 hours total. So you always need to check that when you come on to make sure that the other nurse didn't leave the same bag hanging, because that's gross. Okay. Yeah. And then when they're on TPN, you should be getting Vitals Q4, which you probably were getting anyway, but that's just something important to note. Okay. Do you understand TPN?
Yeah.